Greetings, colleagues. Thank you, Program Director, for the opportunity to present. We looked at the field of practice experiences of South African and Namibian foreign-trained medical practitioners who returned to practice in their own countries. This was a collaborative study. As you can see, there are 5 universities that are taking part in it. By way of introduction, medical practitioners who obtain their qualifications outside their countries need to be integrated in the healthcare system of that country, including South Africa and Namibia, on their return. Now, the field of practice challenges experienced by foreign-trained practitioners have been reported in several settings, and these challenges have the potential to impact on patient care. Exploration, therefore, and identification of these challenges could pave the way towards their resolution. The aim of the study was to explore the field of practice experiences of South African and Namibian foreign-trained medical practitioners who returned to practice in their countries of origin. And the objectives were to explore the relevance of their training outside of their country, to practice in their countries on their return, their reception by fellow medical practitioners and other healthcare professionals, including support staff, and their interaction with senior clinicians serving as their superiors, and lastly, how they compare themselves regarding their clinical performance to their South African or Namibian counterparts. And we followed a qualitative phenomenological study design because we are looking at the lived experiences of these colleagues, and the setting were provinces, at least 5. We are planning to conduct the study there, 5 provinces in South Africa, and of course in Namibia we shall be guided by the setting there. The population will comprise all medical practitioners who are South African or Namibian by birth, who then received their pre-tertiary education in these countries, but then left to other countries to obtain their medical practitioner qualification and returned to practice their medical profession in their home countries. The sampling will be collected through the in-depth interview technique, and the snowball technique will be used because we believe one will have to refer us to their colleagues, and the maximum variation of participants will be achieved by recruiting participants from all known medical institutions where they were given the training. And also we believe the Healthcare Professions Council of South Africa and that of Namibia will be consulted to assist in identifying these practitioners. And the data collection is planned actually to take place during the course of 2024. And of course, I have made data collection through piloting one of such individuals who will be excluded when we come to analysis at a later stage. But I have conducted this interview with her. And the data collection will be conducted by me, the principal investigator, and it is envisaged that data saturation will be reached by the 10th participant, and A participant who develops psychological problems during the interviews will be referred for psychological assistance to a psychologist. We will analyze the data thematically, and the Max QDA software will be used to arrange the data into codes, categories, and themes. And these themes will then form the basis for the study report. Like I have said, I have done a pilot with one individual and in-depth so. And what has emerged are two themes, and the first one being adjustment. The practice focus was found to be different in their country of training versus their country of practice, which was the country where they originated. And they were saying the training was relevant for me to practice in South Africa, though the emphasis was different from that of South Africa. There, the focus being on primary health care, whereas it is curative in South Africa. And the locally used terminology, jargon, once they started using trade names like Adalat, the trainee who had gone outside their country were lost. And of course, they had to adjust over time. And the reception by colleagues was the second theme. And the sub-themes were, it was discouraging. Treatment by my superiors was so bad that at one point I felt like quitting, said the individual. And they were scorned. One senior colleague said to me, "Why did you go to train in X," mentioning the country? "You know nothing." So, colleagues, by way of discussion, there has been report that foreign qualified medical practitioners are treated as inferior by their fellow locally trained practitioners. Now, this relationship betrays the vital interprofessional teamwork and could impact on patient care. Secondly, the challenges in adjustment experienced by foreign-trained medical practitioners is a known phenomenon, colleagues, and emanates from the lack of country-specific knowledge. So, locally trained practitioners can help minimize this stressful situation through early orientation as well as professional and personal support for these, their fellow foreign-trained colleagues. So, in conclusion, any form of discrimination, including medical practitioners' training background, adversely affect patient care and should be stopped. It is recommended, therefore, that it is the responsibility of every healthcare professional to create a collegial and enabling working environment in the interest of optimum patient care. These are my references, and at this point I must thank you and thank you for the collaboration. Thank you, Program Director.
This video was partially sponsored by Dirisana Plus, an EU-funded project.